I'm here with Dr. Robert T. Muller. Dr. Muller is professor of clinical psychology at York University and fellow of the International Society for the Study of Trauma and Dissociation. Dr. Muller is lead investigator on several multi-site programs to treat interpersonal trauma. He's an international speaker with over 30 years in the field and a globally acclaimed author of award-winning psychotherapy bestsellers, including Trauma and the Avoidant Client and Trauma and the Struggle to Open Up. Thank you, Dr. Muller, for taking the time out of your busy schedule.
Thanks so much for having me. It's really exciting, and I really enjoy speaking with you. So fabulous.
Yeah. Well, I've always enjoyed working with you. You offer wonderful workshops, and congratulations on your second book. I have it right here.
Thanks so much.
I just read it. Excellent. It's going to be great for clinicians and those who want to understand trauma in more in-depth detail.
Thanks. It's how I spent my sabbatical. So yes. It took about a year to write, but thanks a lot. Thanks so much.
Okay. In your book, Trauma and the Struggle to Open Up, you place great importance on pacing in therapy. You mentioned that revealing too much too soon makes the client worse. Can you elaborate on the importance of pacing in therapy?
Yeah, absolutely, Jack, for sure. So one of the things that clinicians have been talking about for many years is this concern that by getting people to talk about their traumatic histories and to do so at a time that they're not yet ready for, that can be re-traumatizing. And that concern, people have had that for good reason, because when people reveal too much too soon, what can happen is they can feel this sense there can be this pull to open up because they have a therapist who's empathic and listening. But then what ends up happening is they afterwards might feel humiliated. They might feel this sense of exposure, like, oh my God, I've spilled the beans.
Right, yeah.
And when that happens, that people feel this sense of tremendous exposure, it's very difficult to rebuild trust. And so what very often happens, I've seen this happen, and I give some examples in my book where it's happened with me. People then cancel, and they call you and they leave you that message at 3 a.m. on your message machine or whatever, saying, I'm sorry, I'm not going to be able to continue, but thank you so much for all your help. And you realize, hey, that's confusing. That last session, we talked about all this stuff. But if you go back and kind of play it through, you might realize, okay, you know what? That was our second session. We've talked about all these things. The person wasn't ready for it. And so so in trauma work, what we want to do is we want to pace the process so that people open up at a pace that they can handle. Opening up and talking about traumatic events is very important when people have had years and years of silence, when people have been shut down. But we want to do it at a pace that's right for the person. So that's tricky, you know, and it takes some clinical skill to be able to pace the process.
Now, you and your colleague, Dr. Catherine Clausen, have conducted clinical research on the topic of trauma and different attachment patterns.
Yeah.
Can you share some of your findings?
Yeah. So this is work that we did at Women's College Hospital in Toronto, and it's work that came on the heels of some other studies that I did with Homewood Hospital in Guelph, Ontario. So I've done a couple studies affiliated with short-term treatment programs, and when I say short-term, they're intensive, 8-week treatment programs for people with severe trauma. And part of this challenge with working with people in these short-term programs, I mean, this isn't a year of therapy with someone who has trauma. This is 8 weeks. Now, it's let's say day treatment every day for 8 weeks. But that is, for someone who's had a severe trauma history, 8 weeks is actually pretty fast.
Okay.
And so what happens in some of those studies is, we find change, but the question that we looked at is whether these were sustainable changes, and whether there were changes when we looked at attachment. So part of what we looked at in both of these studies was the person's attachment patterns. And why did we look at attachment patterns? We looked at attachment patterns because it turns out that trauma puts people at risk for an insecure attachment pattern. And it's that insecure attachment pattern that then really gets people into trouble. So when they have a trauma history and they feel insecure about relationships, they cling to people. They don't feel that they deserve to be loved. They feel abandoned if the person goes away, even for a brief period of time. Those insecurities really have an impact on their functioning, on their depression symptoms, on their anxiety levels, on post-traumatic symptoms. So we wanted to see whether attachment patterns themselves were amenable to change in therapy, not just symptomatic change, which we also did find. So the good news was it's good news. We found people did absolutely improve symptomatically. Their post-traumatic symptoms decreased. Their post-traumatic growth increased. So that's the ability to learn from your traumatic experience. That improved. Their psychiatric symptoms decreased. Post-traumatic psychiatric symptoms like flashbacks and things like that decreased. Their anxiety decreased. But in addition to that, they also improved in terms of their attachment patterns. So what we found was that people who had the fearful or unresolved due to trauma attachment pattern, or sometimes it's called disorganized, but this is the most insecure of them all, let's say. That pattern improved in both studies, in both the study that we did at Homewood Hospital in Guelph and the study we did at Women's College Hospital with Catherine Klassen. What we found is that attachment patterns improve with therapy. But what was important to notice in this study, in both of these studies, is that we valued the therapy relationship. In both of these studies, we valued the therapy relationship. And that's what got me really thinking. What is it that happens in the therapy relationship? And it's part of what I'm looking at in my newest workshop, which is also called Trauma and the Struggle to Open Up Relational Strategies to Treat Challenging Trauma Clients. We look at the therapy relationship in order to help people improve their attachment patterns. Because what we find is that this is really important. Attachment is such an important predictor of outcome. And unless we can get at that underlying insecurity, then the question is, are we just doing a Band-Aid solution, or are we getting at something that's really deeper? It turns out that good trauma therapy, trauma-informed therapy, can actually improve attachment as well. And that's different. Other studies haven't looked at that. So that's one of the things we looked at there. That's the long answer to your question.
Because I've worked with
Yeah.
Dr. Gordon Neufeld, and I know you're familiar with his work, a Vancouver-based developmental psychologist. And he's made a career on attachment and placing so much importance on fostering positive and healthy attachments from a very early age.
Yes, absolutely. Yeah. Absolutely. And what we often find when we're doing trauma work with adults, obviously who have trauma histories, is that not only do they have these attachment patterns, like these endure through the lifespan. I mean, insecurity doesn't just pop up overnight. These are people who have been insecure for many, many years, but they also struggle when they need to become parents, and their kids are now getting caregiving from someone who's insecure. And especially if that person gets triggered by their trauma history, then that can affect the attachment patterns of the children. And so we want to intervene at the level of helping people improve their attachment patterns so that they can also be better parents. And we can deal with this intergenerational trauma thing better, right? I mean, that's part of what happens with intergenerational trauma, is that these maladaptive attachment patterns get passed down from one generation to the next. So we want to intervene on that level too.
Excellent.
But yeah, I agree with you very much about, in terms of that observation that Gordon Neufeld has made. Absolutely.
Yeah. Now, you also emphasize, and in your book, the importance of creating a strong therapeutic alliance between the client and therapist to achieve positive client outcomes in psychotherapy. Can you elaborate further?
Yeah, for sure. So therapeutic alliance, the therapeutic relationship, there's lots of evidence, not just from my research, but from the work that other people have done over the years, that the therapeutic relationship is the single most powerful predictor of outcome in psychotherapy. That's true in cognitive behavioral therapy. It's true in psychoanalysis. It's true in family therapy. The psychotherapy relationship is the most important factor. Now, so we know that. We also know that trauma survivors really struggle in relationships.
Yes, definitely.
And it's no mystery, there's a lot of shame and there's a lot of difficulty trusting. And, listen, when you've been through a lot and people have treated you badly, for sure, you're going to have trouble trusting, and it even makes sense. It's understandable. But in the therapy relationship, that gets enacted, this difficulty trusting. And so how do you work with someone like that? So there are a couple things, but one of the things I really focus on in the book is how do you look at, and it's really important to look at, the client transference and the therapist countertransference. And so here what we look at is the what David Wallen calls the interlocking attachment patterns of therapist and client. What are the vulnerabilities the client brings to the therapy situation, and what are the vulnerabilities the therapist brings? Is the therapist someone who really wants to be needed? Is a therapist someone who really wants to be looked up to? Is a therapist someone who really wants to be smart? And all those things are reasonable, but trauma clients very often do want someone to mentor them, do want someone who's smart, do want someone to look up to. And those two interlocking issues can lead to some problematic situations where the client depends on the therapist becomes a little bit of a guru for the client, you have difficulties with helping the client become their own therapist if the client becomes super dependent on the therapist. So there are all kinds of ways in which these interlocking attachment patterns can get in the way of good therapy. But that's part of what we do, is we look at how client and therapist attachment patterns interlock. And that's also something I look at in the workshop, where we also think about our own attachment patterns and what some of our own vulnerabilities are and how those can actually get in the way. Sometimes how they can facilitate improvement, but sometimes how they can get in the way. And if we're non-defensive, if we're open to asking ourselves, what are some things I do in my trauma therapy with my clients that get me into trouble, that aren't always helpful? Well, then we can start to unpack how that gets played out in the therapy relationship. And if you're willing to do that work, boy, you can really improve the work with clients. You can really make some nice change. The other way in which the therapy alliance is something that we want to look at in the therapy relationship is what happens when there's a rupture. So so you've done good work. You thought you were doing everything just fine, and the client leaves you this angry message by email or by phone saying, "You jerk, you did this." And again, trust is an issue for many of these clients. They sometimes can be sensitive. Again, I'm not blaming them for that. They might have very good reason to be sensitive. They've had to watch people very carefully. People have been very hurtful to them. But sometimes you might step into something and trip a wire and then lead the client to react in a certain way, or the client it may not even be that you did anything wrong. It may be actually that you were totally empathic, and that empathy and you did a great job, and that empathy, though, led this particular client to feel vulnerable, and that was too hard for them to deal with.
Right.
And so then there's a rupture. So how do you notice those ruptures? First of all, sometimes it's obvious, but sometimes it's more subtle. What do you do about those ruptures? How do you address them? What's the process? What's the order in which you do different things in order to address the rupture? It turns out there are some things that you should do first, and there are some things that you should wait until you do last. Yeah. And so we walk through those in the book and in the workshop around how to deal with repairing a ruptured alliance. And so
it's easy to get blindsided if you're not really paying close attention to that relationship that's occurring.
Exactly. It's real, and blindsided is exactly the right word to use. It feels like, what? I don't understand. You feel blindsided. Maybe you actually did do really good work and you don't understand what was going on. And so how do you then unpack that, and how do you do that with the client slowly so that you don't have to sacrifice the therapy relationship?
Now, I have another question. Psychotherapy is a telling, a sharing of a personal nature within a safe and secure context. And I know you talk about this in your book. And in your view, what kind of telling is helpful?
Yeah, okay. So I adopt a bit of I draw a little bit on narrative therapy.
Okay.
Not heavily. It's mostly attachment focused, but I do also draw on, it's because it's an integrative approach, the approach I use, because you have to be with trauma clients. But narrative therapists talk about the stories that we tell and the construction of stories. Yeah. Okay. And it's very important that we think about how to help people tell a coherent story about their own life. Many trauma survivors have fragmented memories. And so they've been through, so you think about many rape survivors, why do they make so-called bad witnesses? And I put it in quotation marks because it's only because of our crazy legal system that they make bad witnesses, supposedly. But why do they make so-called bad witnesses? Because what trauma does is it leads to fragmentation of memory. And if you're on the witness stand and if you can't tell a very clear story, people will think that you're lying. Well, you're not lying. You have fragmented memory. And this is part of what happens in trauma, is trauma fragments memories. Why does it fragment memories? Because trauma has not just a cognitive impact, but a powerful emotional impact. And we know from so much cognitive neuroscience research that when affect fits into memory stuff, when you have an emotional connection to a memory, that is so much more powerful than when you're just memorizing stuff that's just, bland material that you have zero emotional connection to. So emotion impacts the memory system. Well, it turns out that if it's overwhelming emotion, it causes the memory system to go haywire, essentially. So when you have overwhelming emotion, there might be things that trauma survivors remember in great detail, and there might be things that they don't remember at all. And it might be obvious things like what bus were they taking? They may not remember, but they may remember that the person who abused them was wearing Nike sneakers. And they can tell you there was a little bit of a mark on the sneakers, and they can remember great detail. But then this other thing, that's the more, quote, obvious thing, they might not remember because the memory system is inconsistently affected by the overwhelming emotion. So part of what we do in trauma, all that to say that the person's narrative is incoherent. It doesn't fit together. They might remember pieces of it, but there might be huge things that they forget. And so in trauma work, part of what we're trying to do is help them construct, in their own, through their own work and through the pieces they remember, not where you're suggesting anything to them, but where you're working with them on what they remember, a story of what happened to them. And you're helping them put into words these feelings that feel so powerful. And that's hard work, but it works at the both cognitive and emotional level. So you're helping them find words, so that's kind of a verbal cognitive task, but you're also helping them create a window of tolerance around the emotion. So as the person is telling pieces of the story and they feel overwhelmed, you might see them sort of dissociate and look away. And you might say, Mary, what's going on for you right now? And she goes, I don't know. And you say, what are you feeling? And she has a word, and then you sort of work with her. Tell me, sit with it. What are you feeling right now? Okay. And you're very gently, in a very careful, gentle, loving kind of way, working with her to look inside and reach inside and see what she's feeling and put it into words. And then you slowly, over time, build a story as to what actually happened. And this might take a little while. This is called creating a trauma narrative. Okay. And it's very, very powerful work. We see this, CBT therapists do this, attachment-oriented therapists can do this as well. So there are many modalities that can use this, but it's quintessentially trauma-informed, where you're helping create a window of tolerance around the emotion, and you're helping them tell a story around what happened to them. And that's easier said than done, but it's very important so that the person can find a way to make sense of what happened to them. So that's what I mean by a telling and creating a narrative.
Wonderful. For people with histories of trauma, there are so many losses which are frightening, which creates a strong desire to disconnect from the therapist and to cut off from a painful past. Is there any value in simply talking about the traumatic past while cutting off from their emotions?
Well, so this is where people have gotten, so it's a great question, and this is exactly where people have gotten into trouble in the past, is where there was this idea of catharsis. Way back in the day, abreaction, catharsis, this idea of get it out, get it out.
Spill the beans.
Spill the beans. And the problem is that without some ability to deal with all the feelings that go with it, it just becomes an exercise. It becomes temporarily, it may feel good in the moment. It's like, oh my God, I got it all out. But it's temporary. It doesn't last. The person, after a little while, still struggles with trauma symptoms. Because why? They don't know what to do with all these feelings. In fact, like I said, they may feel humiliated, and they may struggle, and they may even get angry at the therapist. They might, I told all this stuff, and I don't even know what to do with it all, kind of.
Okay.
They may feel tricked into telling. Et cetera, even though the therapist maybe didn't trick them or do anything wrong, just simply asked an innocent question. But this is where it can be challenging. And so we don't want to be in a situation where we get this huge catharsis of words, a torrent of words, without building the window of tolerance of emotion. Okay. So we want to have the words be attached to manageable feelings. Because it's those feelings that then will come out in relationships. So if the person gets triggered by a boyfriend or gets triggered by a boss or whatever, it's the feelings that are unmanageable. What do you do with the feelings? That's what we got to help the person with. And so we want to be able to help work with affect. It's cognition and affect working together, hand in glove.
Right, and it has to be done very skillfully.
It does, but you can learn how to do this, and it's mostly an exercise in paying attention to things and getting trauma informed. A lot of therapies try to do this work without adequate trauma theory, and that's in the book and in the workshop I'll talk a lot about the different pieces of trauma theory that you need to know in order to be able to do this work.
Right. Excellent. Now, I have one final question.
Sure.
And you noted in your book, Trauma and the Avoidant Client, that familiar themes often emerge when working with clients who are traumatized, and self-deception is one of them.
Right.
Can you shed some light on the reasons self-deception often occurs?
Well, okay. Great question. So self-deception, the idea of it really has to do with the person's relationship with themselves. And, this is why sometimes trauma survivors, get accused inaccurately of lying. They're not lying. It's overwhelming. And so when you're dealing with something that is unbearable, unmanageable, how do you get through your day? Sometimes you have to trick yourself, lie to yourself, kid yourself that things are okay, that it's not so bad, that sort of thing. And so self-deception is a way of not having to deal with something that's just too hard to deal with because you don't have the tools. You don't know yet how to deal with it. Right. You may not even have the language. Some people don't even know the idea of trauma. They just feel awful, and they feel, I deserve to be knocked around. I was a shitty kid. I was a brat. People will say that to themselves, justifying their parents' behavior because what they can't deal with is the fact that their parent really harmed them, and that's just too scary. So there's a kind of self-deception, there's a kind of defensiveness that goes along, and defenses are coping strategies that people need in order to survive. And so we never want to take away a coping strategy. What we want to do is give people options to have new coping strategies. So if someone uses alcohol as a way of numbing the pain, you can't just berate them for drinking. What you have to do is give them good enough reason to do something different, and make the choice that there's got to be something in it for the person to do something different. And when you do that, then the idea of giving up the drinking becomes less painful because it's no longer the only coping strategy.
Yeah, excellent.
So that's how we want to work with people around. And self-deception isn't intended to be something pejorative. It's descriptive. We want to make sure that when we use that language, we are respectful with the idea that sometimes you have to do this in order to survive, and you do this until something better comes along. And that's partly what therapy tries to do, is have something better, something that works better, be in the person's life.
Yeah, excellent. Well, thank you, Dr. Muller. And it's actually Dr. T. Muller. So thank you for taking the time out of your busy schedule. And again, I always enjoy working with you. It's going to be a pleasure organizing your workshops in a number of cities this spring. And I'll definitely see you at our Trauma and Addiction Conference held in Edmonton this spring. So again, congratulations on your recent book.
Thank you so much, Jack. It was a pleasure talking with you.
Okay, likewise. See you soon.
Okay.
Dr. Muller will be presenting at the Trauma and Addiction Conference in Edmonton, held during the month of May, and he will be offering 2-day workshops in Calgary, Kelowna, Victoria, and Richmond, BC this spring. So check out the JackHirose&Associates website, and we hope to see all of you at the events this spring. Bye for now.